Hi everyone, welcome to Pharmacology. So today's video is about local anesthetics. I have already discussed about general anesthetics in the previous video. So today we will learn about local anesthetics. So these are drugs upon topical application or local injection cause reversible loss of sensory perception, especially of pain in a restricted area of the body. Okay, so this local anesthetics provide a reversible regional loss of sensation. They reduce pain and thereby facilitate surgical procedures. Then regarding the site of action, these local anesthetics mainly act on the peripheral nerves. Okay, peripheral nerves, and these local anesthetics are mainly used for minor surgeries or minor procedures. Local anesthetics block nerve conduction of sensory impulses and in higher concentrations block motor impulses from the periphery to the CNS. Cocaine is a naturally occurring compound indigenous to the Andes Mountains, West Indies and Java. It was the first anesthetic to be discovered and is the only naturally occurring local anesthetic. However, it is not used clinically because of its adverse effects and abuse potential. All other anesthetics are synthetically derived. Procaine, the first synthetic derivative of cocaine, was developed in 1904. Mechanism of action of local anesthetics. So the main mechanism is the blocking of sodium ion channels. Okay, so the sodium ion channels are blocked to prevent the transient increase in permeability of the nerve membrane to sodium that is required for an action potential. When propagation of action potential is prevented, sensation cannot be transmitted from the source of stimulation to the brain. So the mechanism means the local anesthetics, what they will do, these local anesthetics will block the voltage gated sodium channels. Okay, so as a result there will be no entry of sodium ions into the cell. As a result there will be no depolarization and it will lead to no generation of action potential. So there will be no generation and conduction of impulse to the CNS and ultimately producing the local anesthesia. All local anesthetics have a similar chemical structure which consists of three components. First one is an aromatic portion, next is an intermediate chain and an amine group. Structurally, all local anesthetics include a lipophilic group joined by an amide or ester linkage to a carbon chain which in turn is joined to a hydrophilic group. The degree of lipid solubility of each anesthetic is an important property because the lipid solubility enables its diffusion through the highly lipophilic nerve membrane. The extent of an anesthetic's lipophilicity is directly related to its potency. Then one important point is that all local anesthetics are weak bases that require the addition of hydrochloride salt in order to be water soluble and therefore injectable. Salt equilibrates between an ionized form and a non-ionized form in aqueous solution. Equilibration is crucial because although the ionized form is injectable, it is the non-ionized base which has the lipophilic properties and is responsible for their diffusion into the nerve cell membrane. Okay, so this is one of the most important classification of local anesthetics. Local anesthetics can be classified into amide and ester type based on the intermediate chain. Okay, so amide local anesthetics include lignocaine, also known as lidocaine, prilocaine, bupivacaine, dibucaine, mepivacaine, etidocaine, and ropivacaine. Then ester class of local anesthetics include cocaine, procaine, chloroprocaine, tetracaine, and benzocaine. And the structure of this local anesthetics is very important. And based on this structure, the local anesthetics are classified as ester type as well as amide type. As I have already mentioned, the local anesthetics, their structure are almost similar. They have got a lipophilic part, intermediate chain, and a hydrophilic part. The lipophilic part and hydrophilic part is same, only the difference in the intermediate chain. In ester type local anesthetics, the intermediate chain is an ester linkage, whereas in amide type local anesthetics, the intermediate chain is an amide linkage. Okay, based on this, the local anesthetics are classified. The duration of action of an anesthetic is determined by their protein binding capacity to anesthetic receptors along the nerve cell membrane. The intermediate chain, which connects the aromatic and amine portions, is composed of either an ester or an amide linkage. So this intermediate chain can be used in classifying local anesthetics into esters and amides. So ester type local anesthetics have a very short plasma half-life. They are readily metabolized by plasma butyrylcholine esterase. In patients with decreased or atypical choline esterase, the plasma levels of these anesthetics may be higher than usual. Then these amide type local anesthetics are metabolized at varying rates and to a varying extent by hepatic isoenzymes and are excreted in an unchanged form by the kidney. The rate of metabolism is decreased in case of liver impairment or by drugs interfering with the microsomal enzyme system. The most widely used local anesthetics are bupivacaine, lidocaine, mepivacaine, ropivacaine and tetracaine. Moving on to the delivery techniques of local anesthetics. So the first one is regional anesthesia. It makes a specific part of the body numb to relieve pain or allow surgical procedures to be done. Local anesthetics are safer than general or systemic anesthetics, therefore they are preferred whenever possible. Next technique is surface anesthesia. It is used during ocular tonometry, intubation and endoscopic procedures. Tetracaine 2% and lidocaine 2% to 4% are used. The anesthetic effect is superficial and does not last long. Next technique is infiltration anesthesia. Here, the local anesthetic is injected directly into the skin or deeper structures to carry out incision, excision, hydrocele, herniorrhaphy, incision and drainage of an abscess, etc. Lignocaine and bupivacaine are generally used for infiltration anesthesia. Fourth one is field block. The local anesthetic is injected subcutaneously proximal to the site where anesthesia is desired. All nerves distal to the site of injection are blocked. Lidocaine 1% to 2% is used for intermediate duration of anesthesia in dental extraction, operation on forearms, legs, herniorrhaphy, etc. Next one is nerve block. Here, the local anesthetic is injected around a nerve plugs or a nerve trunk. This results in a large area of anesthesia. Thus, even with a small amount of drug, a large area of anesthesia can be produced. Lidocaine is most commonly used apart from bupivacaine. Intercostal, sciatic, brachial plexus, facial and phrenic are commonly performed nerve blocks. Sixth one is spinal anesthesia. A single dose of the local anesthetic is injected into the subarachnoid space in the lower end of the spinal cord, that is in the lumbar region. The site of action is nerve roots, resulting in loss of pain sensation and paralysis of the lower abdomen and hind limbs. Lidocaine, bupivacaine and tetracaine are most commonly used for spinal anesthesia. Spinal anesthesia is associated with various complications such as respiratory paralysis, hypotension, headache, nausea, vomiting, bradycardia and septic meningitis. It is used during operations on lower limbs, pelvis, lower abdomen, etc. So the last technique is epidural anesthesia. Here the local anesthetic is injected into the epidural space where it acts upon the nerve roots and relieves pain from large areas of the body by stopping pain signals traveling along the nerves in the spine. In epidural anesthesia, local anesthetic is administered continuously through an epidural catheter that does not reach the cerebrospinal fluid and provides long-term anesthesia and pain relief. The local anesthetics most commonly used for this procedure are lidocaine and bupivacaine. Epidural anesthesia is used during labor to relieve pain or during a cesarean section. It can also be used to reduce the amount of general anesthesia needed during some operations and can provide pain relief post-operatively. In knee and hip replacement surgery, epidural anesthesia can be used in place of a general anesthetic. Pharmacological actions of local anesthetics. All local anesthetics cause vasodilation, which leads to rapid diffusion away from the site of action and short duration when these drugs are administered alone. So by adding the vasoconstrictor epinephrine, the rate of local anesthetic absorption and diffusion is decreased. This minimizes systemic toxicity and increases the duration of action. This is an important point. Usually you might have seen that lidocaine is usually co-administered with epinephrine or adrenaline. So what is the benefit or what is the advantage of this combination? So by adding this vasoconstrictor epinephrine, what will happen? The rate of local anesthetic absorption and diffusion is decreased. This minimizes the systemic toxicity and increases the duration of action. This is a question usually asked in most of the competitive exams. So this is very important. The advantage of combining lidocaine with the epinephrine. Okay. So in order to increase the duration of action as well as to minimize the systemic toxicity. However, epinephrine should not be co-administered for nerve block in extremities such as fingers and toes, as vasoconstriction of end arteries may lead to ischemia and necrosis. It should be used with caution in patients with thyrotoxicosis or cardiovascular disease and in labor. Hepatic function does not affect the duration of action of local anesthesia because that is determined by redistribution rather than biotransformation. Some local anesthetics have other therapeutic uses. For example, lidocaine is an intravenous antiarrhythmic drug. Onset, potency and duration of action. The onset of action of local anesthetic is influenced by several factors including tissue pH, nerve morphology, concentration, pKa and lipid solubility of the drug. Of these, the pKa is the most important one. Local anesthetics with a lower pKa have a quicker onset. Okay, so this is an important point. Local anesthetics with a lower pKa value have a quicker onset of action since more drug exists in the unionized form at physiologic pH, thereby allowing penetration of the nerve cell membrane. Okay, so the local anesthetic activity is pH dependent and penetrability of local anesthetic is increased at alkaline pH. Okay, and the onset of action is related to the pKa of the drug. Higher the pKa, more ionized fraction at the physiologic pH, that means slow acting. And if lower the pKa, for example lidocaine, mepivacaine, they are fast acting drugs. So once at the nerve membrane, the ionized form interacts with the protein receptor of the sodium channel to inhibit its function and achieve local anesthesia. The pH may drop in infected sites, causing onset to be delayed or even prevented. Okay, that is meant by that the penetrability of this local anesthetic is poor at a acidic pH because the pH may drop in infected sites, causing onset to be delayed or even prevented. Potency and duration of these agents depend mainly on lipid solubility, with higher solubility correlating with increased potency and duration of action. Metabolism. Biotransformation of amides occurs primarily in the liver. Prilocaine, a dental anesthetic, is also metabolized in the plasma and kidney, and one of its metabolites may lead to methemoglobinemia. Esters are biotransformed by plasma choline esterase, that is the pseudocholine esterase. Patients with pseudocholine esterase deficiency may metabolize ester local anesthetics more slowly. Reduced hepatic function predisposes patients to toxic effects but should not significantly increase the duration of action of local anesthetics. So regarding the metabolism of amide local anesthetic is primarily carried out by the liver, whereas the esters are biotransformed by the plasma choline esterase. Now moving on to the allergic reactions. Patient reports of allergic reactions to local anesthetics are fairly common, but oftentimes reported allergies are actually side effects from the co-administered epinephrine. True allergy to an amide local anesthetic is exceedingly rare, while the ester procaine is more allergenic and has largely been removed from the market. Okay, so the allergic reactions due to amide local anesthetics are rare, but the allergic reactions due to ester local anesthetics are more common, especially with this procaine. That is why this drug has been largely removed from the market. Allergy to one ester rules out use of another ester because allergenic component is the metabolite para-aminobenzoic acid, which is produced by all esters. By contrast, allergy to one amide does not rule out the use of another amide. A patient may be allergic to other compounds in the local anesthetic such as preservatives in multi-dose vials. Local anesthetic systemic toxicity. Toxic blood levels of a local anesthetic may be due to repeated injections or could result from a single inadvertent IV injection. Each drug has a weight-based toxic threshold that should be calculated. This is especially important in children, the elderly and women in labor who are more susceptible to local anesthetics. Aspiration before every injection is imperative. That means aspiration before every injection is very important. The signs, symptoms and timing of local anesthetic systemic toxicity are unpredictable. One must consider the diagnosis in any patient with altered mental status, seizures or cardiovascular instability following injection of local anesthetic. Treatment for local anesthetic systemic toxicity may include seizure suppression, airway management and cardiopulmonary support. Administering a 20% lipid emulsion infusion, that is lipid rescue therapy, is a valuable asset. So in this slide, you can see the summary of pharmacologic properties of some local anesthetics. Okay, so in the first column, there is ester local anesthetics. Examples include benzocaine, chloroprocaine, cocaine, procaine and tetracaine. And what all are their specific properties or their characteristic features. And in this column, you can see the amide local anesthetics. Examples including bupivacaine, prilocaine, lidocaine, ropivacaine and mepivacaine. And what all are their characteristic features. And also their potency, onset and duration of action of these local anesthetics are compared. So we have completed local anesthetics. Now we will see anesthetic adjuncts. Anesthetic adjuncts means these drugs are used in collaboration to help make the anesthetic experience safe and pleasant. Or else we can say that these drugs will help to facilitate or smoothen the anesthetic procedure. Adjuncts include drugs that affect the gastrointestinal motility, postoperative nausea and vomiting, anxiety and analgesia. So the first one is gastrointestinal medications. H2 receptor antagonist, for example ranitidine, and proton pump inhibitors such as omeprazole helps to reduce gastric acidity in the event of an aspiration. Then non-particulate antacids such as sodium citrate or citric acid are given occasionally to quickly increase the pH of stomach contents. Finally, a dopamine receptor antagonist, for example metoclopramide, can be used as a prokinetic agent to speed up gastric emptying and increase lower esophageal sphincter tone. Next is the medications for postoperative nausea and vomiting. Risk factors for postoperative nausea and vomiting include female gender, non-smoker, use of volatile and nitrous anesthetics, duration of surgery, and postoperative narcotic use. So the medications mainly used are 5-HT3 receptor antagonists, for example ondansetron, are commonly used to prevent postoperative nausea and vomiting and are usually administered toward the end of surgery. Caution is advised in patients with long QT intervals on ECG. Then an anticholinergic and antihistamine, for example promethazine, can also be used. However, sedation, delirium and confusion can complicate the post-operative period, especially in the elderly. Then glucocorticoids such as dexamethasone can be used to reduce post-operative nausea and vomiting. The mechanism is unclear, but because of a longer onset, these agents are usually given at the start of surgery. The neurokinin 1 antagonist, aprepitant, has also been shown to reduce postoperative nausea and vomiting. Lastly, transdermal scopolamine is given preoperatively to patients with multiple risk factors or to a patient with a history of postoperative nausea and vomiting. Caution is advised because it can produce central anticholinergic effects. Third category is the anxiety medications. We all know that anxiety is a common part of the surgical experience. So benzodiazepines such as midazolam diazepam, alpha-2 agonists such as clonidine, dexmedetomidine, and H1 receptor antagonists such as diphenhydramine can be used to alleviate anxiety. Benzodiazepines also elicit anterograde amnesia, which can help promote a more pleasant surgical experience. And the next one is analgesia, which means the pain relief. Non-steroidal anti-inflammatory drugs such as ketorolac, celecoxib are common adjuncts to opioids. Caution should be used in coagulopathy, gastrointestinal, mucosal and platelet aggregation susceptible patients. Paracetamol can be used both peroral and intravenously, but caution is advised in impaired hepatic function. Then analogues of GABA, for example gabapentin, pregabalin, are becoming more common as pre-treatment to reduce opioid consumption both during and after surgery. They also have multiple uses in neuropathic pain and addiction medicine. Then the last one is the NMDA antagonist, which is example is ketamine. It is used to reduce overall opioid consumption both intra and post-operatively. So we have completed the local anesthetics chapter. If you have any doubts, you can mention in the comment section. Please like, share and subscribe. Thank you everyone. Thank you for watching this video.